Great. Good afternoon, everyone. My name is Athea Chaudhry, and I am a Senior Program Manager for the Health Systems Transformation Team at the Association of Maternal and Child Health Programs, or AMCHIP. I'm excited to welcome everyone to our second virtual learning session for the Promoting Innovation. I'm sorry, is there
Yeah, I just saw him, yeah.
Yeah, and let me know when you...
Thank you.
Great. And as a reminder, if folks could mute themselves. I'm excited to welcome everyone to our second virtual learning session for the Promoting Innovation in State and Territorial MCH Policy-Making Learning Community. This learning community is co-organized by AMCHIP and the Association of State and Territorial Health Officials, or ASTO. Next slide, please.
Hello.
Hi, we hear someone saying hello. Can you please put yourself on mute? Thank you. All right, Athea, go ahead.
Thank you for those who have chatted in where they're from. For those who are joining now, please take a moment and type in your state into the chat box. Today's session will discuss maternal mental health systems change, a topic relevant to the policy goals that many of the teams represented here today are working on as a part of this learning community. So just to read out from the chat box, we have representation from Arkansas, Virginia, New Mexico, and California. So continue to let us know where you're from through the chat box. For the agenda today, we are thrilled to have the opportunity to hear from 3 presenters who will offer their expertise on different aspects of maternal mental health systems change. Materials for today's webinar, such as speaker bios and handouts, are attached in the calendar invite that was sent to you all. Next slide. To review the objectives, for today's learning session, we hope you'll be able to describe how maternal mental health and substance use disorder systems changes can lead to increases in diagnosis and treatment rates, identify ways to utilize the lifting of the Medicaid Institutions for Mental Disease, or IMD exclusion, to improve treatment of mental health and substance use disorders, and delineate the process by which Virginia leveraged a Medicaid waiver to improve access to care and treatment for mental health and substance use disorders. Please note, before we turn it over to our speakers, we would like to state that the content, findings, and conclusions shared in this presentation are those of the speakers and do not necessarily reflect the official position of or endorsement by either ASTO or AMCHIP. Please do not hesitate to reach out to any member of the ASTO or AMCHIP teams if you have any questions about this disclaimer. And now it's my pleasure to introduce our first speaker, Joy Burkhart. Joy is the founder and executive director of 2020 Mom, an organization dedicated to closing gaps in maternal mental health care through education, advocacy, and collaboration. Just as a reminder, we will hold questions until the end. So during your presentation, please feel free to type your questions into the chat box, and we will answer the questions at the end of all 3 presentations. Joy, I'll turn it over to you.
Great. Well, thank you so much to the ASTO and AMCHIP teams for having me. It's a pleasure to be back and be sharing a little bit about our work at 2020 Mom with regard to maternal mental health. And I really do look forward to supporting all the state teams in any capacity that would be helpful and relevant throughout your work in the PRISM project. We can go ahead and advance to the next slide. I wanted to start by sharing just a little bit about who 2020 Mom is. We were formed 8 years ago, actually yesterday, our official launch 8 years ago at the suggestion of the California legislature. We were formed first as the California Maternal Mental Health Collaborative, and you'll see perhaps if you do a landscape review that several other states have formed similar collaboratives of various stakeholders, Florida, Utah, Colorado, and changed our name after we launched a program called the 2020 Mom Project, which highlighted the roles that hospitals as the hub of birth and also insurance companies can play in advancing policy change and systems change in maternal mental health. And we're now known as 2020 Mom, working both at a state level, our home base here in California, doing a lot of work, but also supporting advocacy groups throughout various states to do state policy work and also leading national policy change around maternal mental health. Our mission is to close gaps in maternal mental health care. You heard that earlier. And kind of the core of our belief is that if families, employers, and society are paying for healthcare benefits, then they ought to be available. And we all have heard that that's not often the case with regards to mental health. And we'll go into some of that today. We can move on to the next slide. So I always start presentations with these statements, and bear with me because I want to read them slowly so that they can sink in for you. So did you know that women in their childbearing years account for the largest group of Americans with depression? Did you know that postpartum depression is the most common complication of childbirth? Did you know that there are more new cases of mothers suffering from maternal depression each year than women diagnosed with breast cancer? Did you know that new onset of maternal depression occurs almost as frequently in pregnancy as it does in the postpartum period? And did you know that the American Academy of Pediatrics has noted that maternal depression is the most underdiagnosed obstetric complication in America? And so despite the prevalence, maternal depression largely goes undiagnosed and untreated. And we'll talk about some of the whys behind that statement and what's been happening from a national perspective throughout my presentation. We can move on to the next slide. So if you're like me, you want to know what is the latest from the national bodies, the trade associations around maternal mental health. And we always like to start with and acknowledge the leadership of the American Academy of Pediatrics. AAP was the first trade association to acknowledge the problems with untreated postpartum depression. In particular, that lens has widened, of course, as our conversations and understanding that these disorders are bigger and more than depression, but also occur during pregnancy. So a shout out again to the American Academy of Pediatrics for being the first to acknowledge the importance and also acknowledge the importance to early childhood development when a mother is not, or primary caregiver is not available to interact with the baby as we were intended to. Also, then you're wondering probably, what about the American College of Obstetrics and Gynecology? And we're so excited to announce that in 2017, really it was ACOG's leadership that began as a tipping point for other organizations to start to take another look at the recommendation for screening depression and anxiety. They recommended that change in 2017. Prior to that, the statement was that there wasn't enough evidence to support screening. ACOG also wisely has indicated that screening should happen and that systems must be put in place to refer patients to proper treatment. We also want to point out that at the American College of Obstetrics and Gynecology in 2019, so earlier this year, you probably have heard about the fourth trimester, a redesign of the fourth trimester period by ACOG to deliver postpartum care. So recognizing that there's more that an OB should be doing past that first postpartum visit, or for a cesarean, a second postpartum visit, that really there's a fourth trimester that must be looked at. Also, is the ACOG position that encouraged the U.S. Preventive Services Task Force to take another look at whether they should recommend screening. Previously, pregnant women in particular were excluded from the U.S. Preventive Services Task Force recommendation that all adults be screened for depression. And in 2017, their position was updated to recommend that both pregnant and postpartum women, in addition to all of adults, be screened for maternal depression. Also, this year, or actually in 2018, we really want to point out something that we haven't seen the U.S. Preventive Services Task Force do before, and that is to recommend screening for risk in order to prevent, which again, that ties back to the name of the agency, right, or the task force, screening to identify risk for those at risk for postpartum depression or maternal mental health disorders, with the eye on preventing maternal mental health disorders. And they elevate the mechanism for doing that as programs like CBD, providing cognitive behavioral therapy. If you haven't seen that recommendation, I highly recommend that you take a look, and we're happy to share a link to that recommendation so it's handy. All of this being said, we still like to point out that the Agency for Healthcare Research and Quality, another federal agency, has generally stated that it can take up to 20 years for recommendations like these to become mainstreamed. Just recently, AHRQ reported that only 35% of adults were screened for depression, a report that came out this year based off of 2015 data. And so, of course, we know that just because there's a recommendation to screen doesn't mean that there aren't significant barriers in a primary care setting, or in our case, an obstetric setting, to screen. Next slide. So as a patient advocacy organization who's really been working very thoughtfully with multiple stakeholders, one of our lanes and interests has been looking at how do we effectuate this change and shorten this timeline? Who needs more support? How do we do that, both with carrots and sticks, this nice sort of balance for effectuating change? And we wanted to share, I think some of you may know about the Bringing Postpartum Depression Out of the Shadows Act. It was signed into law in November 2017 by Obama as part of the 21st Century Cures Act, and it provides grants, or provided grants to states. At least 7 were selected and provided grants last year by HRSA. You can see those 7 states listed here on the slide. And the focus of this grant really was looking at what Massachusetts has done to leverage telepsychiatry consultation programs. So we know one of the barriers that obstetricians and pediatricians face, and primary care providers generally face, is that they don't know what to do once a patient has a positive screen, and then there is an expectation on many fronts that they treat baseline depression and anxiety. And Massachusetts has really led the way through their Child Psychiatry Access Program that was called to be created by a judge after a school shooting years ago, not a recent school shooting in Massachusetts. They created the Child Psychiatry Access Program for pediatricians, and then that model was expanded to be called what we hear as MCPAP for Moms, so Massachusetts Child Psychiatry Access Program for Moms. And so it's really looking to look at telepsychiatry models and consultation programs and expansion into rural areas, etc. You can move on to the next slide. I'm just giving you a quick snapshot of the states that have looked at legislative change. So again, we know there's been action on a federal level. There's something that's being addressed at a federal level around the development of a task force, an interagency task force. We'll have an update on that later. But many states have also taken action. We, of course, want to see no white space on this slide, because we think it really does likely require a legislative push to help prioritize this issue. But here's a snapshot of the states that have taken action. We'll move on to the next slide, and I'll go into what states took action most recently, starting with the 2018 legislative cycle. Many states, or several states, have started to introduce awareness resolutions declaring the month of May Maternal Mental Health Awareness Month. Utah and Michigan did that again recently in 2018. Several other states have also done that and declared the month of May forevermore, in perpetuity, as Maternal Mental Health Awareness Month. Maryland has also taken some strong legislative action because of problems with funding with the new governor. Some of that action actually hasn't been put into place, but you can take a look at what the legislature prioritized before the Republican governor took office. I also want to share that Florida has taken some great action. The Families First Act of 2018, you can read about that. And then California passed several laws, including a hospital law and a mandated screening law. So obstetric providers are required to screen and insurance companies are required to support. We'll take another quick look at the next slide, 2019 legislation. A quick peek at this. Utah actually addressed maternal mental health through funding of early childhood intervention program that was already in place to expand it to include maternal mental health. Virginia expanded something that was already in place to include anxiety, which is as prevalent as depression and often is a precursor to maternal depression. And then there's a couple other bills listed here for California, and then Pennsylvania has taken made a lot of attempts to address maternal mental health. All right, next slide, please. I also just want to quickly point out that New York has done some interesting work around maternal mental health because you heard me mention earlier that new onset of maternal depression is or anxiety or maternal mental health disorders are really as prevalent during pregnancy as in the postpartum period, that there has been a movement for states and other organizations to look at obstetricians as the primary screening entity. You'll see that second sentence here, though New York has noted that reimbursement is available for obstetricians, gynecologists, pediatricians, that there is a bit of a challenge in how that funding and payment works, that it's not the intent for services to be duplicated by both the pediatrician and the obstetrician. So there is some coordination that's required. It's really why some states and organizations are starting to really point to obstetricians to be the home base for screening and diagnosis and development of treatment plans versus the pediatrician. The other barrier, of course, with the pediatrician is that the pediatrician is not the mom's treating provider. And so it's difficult to create treatment plans, referral, protocol, etc. Medical record privacy issues exist as well. I have just a few minutes left, so I'm going to go through the other slides quite quickly. We'll go ahead to the next slide. So I just wanted to point out that what we've started to see is a recipe for success is development of blue ribbon commissions or even legislative commissions. If legislature is interested to study maternal mental health, we think that this could be expanded, of course, to include substance use as well. Really timely to include all of these things and think about screening, etc., referral pathways collectively. This is the recipe that several states have recently followed. We'll go on to the next slide. We'll actually skip this. I think all of you know sort of understanding root causes that are important. We already talked about Massachusetts, but they really led the way in creating a system of change. They have not mandated screening. It's worth taking a look at their work. We can go on to the next slide. The other states that have ran task forces or commissions are listed here on the screen. Maryland, Utah, we hit on already, and Florida, California also. We'll move on to the next slide. I just want to quickly touch on California and what's happened here. It's the state that has passed the most legislative action. It's really propelled some of the state agencies to take some great action as well. Next slide. This task force of multiple stakeholders said that it's important we have a goal and that we know whether our recommendations are being put into action. And they set a goal to have 100% of screening rate, recognizing 100% is always hard to achieve, but all moms deserve to be screened for these disorders by the year 2025, and a stopgap rate at 80% by the year 2021. Again, this task force, similar to what I've hinted at already, emphasized that OBGYNs should be the home base for screening, and that there also needs to be recognition that there should be no wrong door for screening, that various community-based organizations, pediatricians, others like lactation consultants, et cetera, should also be screening, particularly when a mother raises concern that the OBGYN should be the home base, which was really a missing core in maternal mental health prior to this point. Next slide. Quickly, here's some work products that came out of the California white paper from this task force, core competencies that all providers should have, different provider groups, a continuum of care, what are the impact points for mothers, screening score cutoff, so there isn't one agency or one organization that says if you have a 9 on this tool or a 10 on this tool, you need to take action, and also when do we screen. So those recommendations are included in the report, a menu of treatment options that are evidence-based, and detailed recommendations for all stakeholders. Next slide, and then I'll wrap up. Other states that I want to make sure you know about that are leading change. I know Iowa is part of the PRISM program. Hats off to you, Iowa, for recognizing the importance of home visiting, a public health program, particularly for low-income communities. We know that this makes a difference, and not all low-income women attend OB appointments, and so a really important lever. We also wanted to give a shout out here to Colorado, who's done some great work. I know Kat, who has pulled us all together, is going to share some information with all of you post this survey on what Colorado has developed. I've included a couple of links here that you might find interesting as well, but there were several other handouts that Colorado has shared with us that we want to pass on to you. And I think we'll go ahead and wrap up. I do have a slide with my contact information.
I think we may have lost Joy. Joy, are you there?
I sure am. Can you hear me?
Yes, we can hear you now. We just lost you there for a second.
Oh, okay. I'm not sure what happened. I am here, and I just wanted to wrap up. Here are some resources from us that Kat had shared previously, and we'll follow up with for you. I also just wanted to share we have an e-newsletter, and we have various blog posts on policy from throughout the United States and at a federal and state level that you might be interested in. So take a look at our website, and then the last slide here is my contact information. There we go. And then we'll wrap up. There are a couple other slides around core barriers that we won't go through today. I think Kat will just skim through them quickly so you can see them that come from that California white paper. This white paper has been referred to as the nation's white paper, not just California's white paper, so really can serve as a model. Thank you so much for the time, and I look forward to hearing from the other presenters.
Thank you so much, Joy. As a reminder to participants, please chat in your questions during the presentations. If we don't get to them on the call, we will certainly send out responses to your questions afterwards. So I will now introduce our next speaker, Deb Fournier, for our second presentation. Deb is the Senior Director of the Clinical to Community Connections team at ASTO and the former Medicaid Director of New Hampshire. I'll turn it over to you, Deb.
Great, thanks, Ashley. Hi, everyone. We are going to do some nerdy exploration of Medicaid's IMD exclusion so that you understand the potential opportunities around the IMD exclusion and the infrastructure that states have to interact with when they are trying to improve access to substance use disorder treatment. Next slide, please. So just a quick reminder, Medicaid is a publicly funded health insurance program. It was enacted in 1965. In general, historically, Medicaid has covered kids and expectant women, older folks, and people with disabilities with relatively low incomes. And next slide. This is important. This background. Can I have the next slide, please? This background is important because of the role that Medicaid plays for folks all over the country. As you can see, for the folks with low income, they are a significant source of coverage. For families, especially for moms and kids, they are a significant source of coverage. They cover nearly, across the nation, nearly half of births. And then, not for today, but just as a general rule, Medicaid is the dominant provider of long-term care services in the country. Next slide, please. So When we're talking about the IMD exclusion, IMD stands for Institution for Mental Disease. Now, remember, Medicaid was enacted in 1965, and so the law, as it was written, said that Medicaid couldn't make payments to states for services or care for any individual who is a patient in one of these institutions for mental disease. And then you can see the definition, how the statute defines what is considered an institute for mental disease. Historically, in the United States, people with severe mental illness and developmental or intellectual disabilities had been warehoused in large public institutions that were the state's responsibilities. I think at best you could characterize the care that some people received in these institutions as subpar. And in the worst case scenarios, in some instances, you could characterize the care they received as abusive. So the federal government was concerned both about being on the receiving end of the bill for paying for folks in these large institutions, but also did not want to be encouraging the continuation of what was considered warehousing of people. And so it crafted in this large statute, the Medicaid statute, this carve out that's saying we won't help you pay for services rendered for people with mental diseases if they have 16 or more beds. So the feds are saying to the states in this instant, those large mental hospitals or psychiatric inpatient institutions that you pay for, we don't want to help pay for those. The other thing that we need to recognize is that at the time that this statute was written, substance use disorder was considered, it is defined as a mental disease. And so this included, or de facto includes, institutions with more than 16 beds that provide substance use disorder treatment. Next slide, please. So this has been increasingly an issue in the wake of the opioid crisis that the nation has been grappling with for several years now. And there have been little bursts in the dam of Medicaid's exclusion of paying for services for people residing or receiving care in these facilities. So the first workaround is a rule that the Centers for Medicare and Medicaid Services, which is the agency that oversees the Medicaid program and it partners with the states in operating their programs, promulgated a rule that said that in certain instances, a state could get matching funds, which is how Medicaid helps to support funding for Medicaid programs and services, is by sharing the funding with the states. That states could receive some of those federal matching funds for someone who is otherwise Medicaid eligible, who was receiving inpatient care in an institution that met the definition of IMD. If they were in that institution for up to 15 days a month, and the state made the case that it was in lieu of other services that Medicaid did have covered in its state benefit package. So the in lieu of, the things in quotes there on that slide, is an opportunity where a state can say, we paid for this service that is not included in our Medicaid plan, but it is clinically appropriate and it is cost effective, and it's a substitution for a service that Medicaid does cover. So obviously, for anybody doing substance use disorder treatment, 15 days in a month for someone who is receiving inpatient or residential care is problematic, although the math around in lieu of making the argument that treating someone inpatient is more cost effective or more clinically appropriate than providing them with a different Medicaid service is very, very feasible. So the next way that states could provide payments to institutions for mental disease is through something that's pronounced a DISH payment. And this is wherein essentially Medicaid gives a payment to hospitals in the state that have a high proportion of Medicaid beneficiaries and other lower income patients. And so this wasn't a direct payment for Medicaid beneficiaries who were there for long-term payment, but it was a way to say to the institution for mental disease, the IMD, or the facility that qualified as one, here's some Medicaid funding for the folks that we know are Medicaid beneficiaries, but for whom we can't properly pay you because we're excluded from doing so. Next slide, please. So what do you do when you are faced with rules like these? Well, you find a workaround, and the workaround in this instance are waivers. So this is the sort of legal way that states can seek flexibility, and they can seek flexibility through waivers in a number of ways. You can see the two there. We're going to focus on the second one, which is to test innovation and to promote state priorities or state policies. Next slide, please. So the 1115 is a type of a waiver. It actually references a component of the statute, of the Medicaid statute, section 1115. And this is a provision that allows a state to get permission from the Centers for Medicare and Medicaid Services to use Medicaid funds in ways that are not necessarily the way they are usually allowed to use them, to carry out an experiment or a pilot or a demonstration. So an experiment, so long as the objective of that experiment assists or is likely to assist in promoting the objectives of the Medicaid program. So folks have been, next slide please, using 1115 waivers to try to address the need that states are confronting of providing intensive inpatient or long-term treatment for both substance use disorder treatment and for mental health treatment to people in large facilities. So the first way, the first actual break in the dam, not just the little leaks that we were talking about before, is something that Medicaid nerds like to call sub-regulatory guidance. So these are essentially memos or briefs that CMS sends to the Medicaid directors and the state health officials in the states to tell them how they are thinking about implementing policy. So these are issued not in any consistent interval, but regularly. And the first one came out in July of 2015 and said, you know, we will let you no longer go through the in lieu of exercise. You can just get federal match for inpatient treatment for folks who need it for substance use disorder treatment only. And again, for the 15-day limit. However, the guidance also said that in order to get this type of waiver approval, the state would also have to promise to cover community-based services and institutional services that supplement but don't replace community-based services. Next slide, please. So this evolution continued. In November of 2017, additional guidance came out suggesting that this time limit was more flexible and outlined additional parameters for states to get one of these waivers. Again, the waivers were targeted for people with substance use disorder treatment only. CMS was not addressing the use of payments to support treatment for folks in institutions that would qualify as institutions for mental disease if they were there primarily for mental health purposes. The criteria that a state had to establish with CMS in order to win approval of these waivers required coverage of certain outpatient and residential services, provider requirements, evaluation requirements, and reporting requirements. And then the next year, more guidance was issued indicating that states would be allowed to obtain these waivers against or to remove the exclusion of these payments for certain groups of individuals with serious mental health conditions. So in a relatively short period of time, there has been a lot of movement at the federal level to try to align federal resources with the need that the states are experiencing with respect to increasing capacity to provide substance use disorder treatment options to the people in their states. Next slide, please. So, as of August of 2019, just about half of the states have received approval for waivers that allow them to receive payment for folks receiving treatment in IMDs for SUD related concerns. So, and there are still 5 states with outstanding applications for IMD payment. The waivers initially approved under the prior administration tended to specify numeric day limits. So for example, Maryland's waiver allows someone to receive payment, or I should say, for the state to receive payment on behalf of someone who had 2 30-day stays in an institution that was considered an IMD. And California's early waiver allowed for 2 90-day stays if the beneficiary was an adult, or 2 30-day stays if the beneficiary was an adolescent. The more recent waivers approved under the guidance that we just talked about don't have explicit day limits, although some of them have language in them that says that the state's going to aim for a statewide average length of stay as a way to try to ensure the federal government that these really are short-term stays, and that the state isn't just paying for open-ended treatment for folks. And while the 2017 guidance did note that there was states were going to have to demonstrate how they implemented what their implementation plan was, some of those, not all, some of those state waivers ultimately don't detail the services across the care continuum as much as the earlier waivers do. But they are substantial, and they open capacity for a lot of states. And as you can see from the list, it's a variety of states. They are not in any one region. They are not in any one demographic, topographical landscape, in the country. And then one state has won an approval for an IMD payment exclusion waiver for folks with mental health treatment, and that is Vermont. The District of Columbia is still waiting to see if its waiver will be approved. Next slide. So the most recent update on the IMD exclusion is the Support Act, which was passed last fall by Congress and provided a lot of updates to resources for the state for those confronting opioid addiction. Can everyone put their phone or their computer on mute? We're still hearing some background noise. Thank you. So the Support Act, in fact, sort of temporarily eliminates the IMD exclusion for the next 4 fiscal years starting in October. And states can cover with Medicaid funds, as you can see, services for people with at least one SUD disorder for up to 30 days over a full year's period. This does not extend to mental health treatment. And there's another provision that for women who are eligible on the basis of their pregnancy, this is sort of a weird double negative, but the state can't deny the federal match for non-IMD services to someone who is pregnant and within her 60-day postpartum eligibility for Medicaid that are patients of an IMD for SUD, meaning the state can still receive federal match for her medical services that she requires, even though she might be in an IMD that would otherwise preclude the state from receiving a federal match for her care. Also, I think what's notable about what happened in the Support Act is that the states have to ensure that the IMDs that they place or allow their Medicaid beneficiaries to receive services in, they have to offer 2 or more forms of medication-assisted treatment as a way of increasing access to this treatment method that we know has a solid evidence base. So I think that brings me to the end of my, next slide please, to the end of my comments. I'm happy to take questions at the end. And thanks for all the wonderful work that you're doing on behalf of women and their children. Back to you.
Thank you, Deb. Now I will turn it over to our third presenter today, Ashley Harrell, the Senior Program Advisor for the Division of Behavioral Health at Virginia's Department of Medical Assistance Services. Ashley, over to you.
Thank you. So thank you again for having me today and be able to share Virginia's experience with our substance use disorder program, especially around pregnant and parenting women with substance use disorders. Next slide. So this shows you just an overview of the opioid epidemic in Virginia from 2012 to 2015. Virginia experienced a slow increase in the fatal overdoses from opioids. However, this was a change in 2015 where we had a sharp incline in opioid fatalities through 2017. So very similar to what other states were experiencing. Next slide. So the Virginia Governor and General Assembly noted that Medicaid had a significant impact in being able to reduce the opioid-related fatalities, and in the spring of 2016 funded the transformation of the Virginia Medicaid substance use disorder benefit. There were 6 major components listed here. One was expanding short-term inpatient detoxification to all members, expanding short-term substance use disorder residential treatment to all Medicaid members, increasing reimbursement rates, adding peer recovery support services. We carved this into our managed care contracts and also required that there were licensed care coordinators with substance use disorder knowledge and experience at each of the MCOs, and then a significant statewide training for providers, not only for education, but for recruiting into the Medicaid network. Next slide. So as we've discussed about the 1115 substance use disorder demonstration waiver, this was something that Virginia pursued, and it allowed us to be able to draw down those federal financial participation or FFP funds for residential facilities that had greater than 16 beds. This increased the provider capacity in Virginia for this level of care significantly. CMS also had several requirements for Virginia to approve the 1115 demonstration waiver. One of these were to move to recognizing a nationally evidence-based model of addiction treatment, which was Virginia chose to use the American Society of Addiction Medicine. It also required Virginia establishing the full continuum of community-based levels of care. Part of the special terms and conditions of our demonstration waiver was to contract with an independent evaluator to do a very in-depth, robust evaluation of our program, and that's something that we report on annually and also have interim reports. Also wanted to point out that CMS requires that states who have an 1115 waiver keep the residential stays are considered short-term. So looking at these various levels of care within residential, we have to have a statewide average length of stay of no greater than 30 days. So we see that our more higher intensity clinical, medical residential levels of care may have shorter lengths of stay. And then if you look at, if you're using the American Society of Addiction Medicine, if you're looking at more of the ACM level 3.1, which is more of kind of in Virginia, kind of a group home model, that might be longer lengths of stay, but we have a formula that CMS has approved that we're well under the 30-day average. And then also, we utilize the 1115 waiver only for waiving the IMD requirement, and we did a state plan amendment to add the other services, non-residential services, into our Medicaid state plan. Next slide. So one benefit, this is the ACM Continuum of Care. One benefit with not only for Medicaid members in requiring this as a standard of care, it also actually raises the standard of care for providers who are also serving other patients, including those privately insured. So kind of a win-win situation. Next slide. So this is the, in Medicaid, we call it our Addiction and Recovery Treatment Services Program, or benefit, or ARTS benefit, and this is the umbrella of services that also aligns with the ACM Continuum of Care. And another significant component within Virginia is we are a managed care state, and so we did carve this into our managed care contracts. So now our MCOs not only cover the physical, but they also cover the full spectrum of behavioral health care as well. Next slide. So there were several critical elements to a successful implementation and transformation of the benefit. One very significant was political support. So our executive branch agencies within Virginia formed a statewide working group to end the overdose epidemic in Virginia. And this group was very supportive of the Medicaid transformation and still is. Second, it's looking at your stakeholders and having their engagement. And so in Virginia, this included providers, provider associations, our managed care entities, as well as other state agencies. There was having a common goal or shared agenda is beneficial, and this helped to increase access to prevention and treatment services, ultimately to reduce the overdose fatalities, as well as emergency department visits and hospitalizations due to addiction. Another component is access to data so that you can evaluate what the true need is within your state, as well as outcomes. And then also having the Medicaid support by increasing provider capacity. We did this through having some enhanced rates and providing extensive technical assistance and education. Next slide. So key partnerships, we worked, this was not a Medicaid alone initiative. We worked very closely with our State Department of Health and our Department of Behavioral Health. They helped us with promoting statewide trainings for providers as well as our managed care organizations, and that included training on the ACM criteria and included offering the buprenorphine waiver training for prescribers. We've also utilized through several universities, our health department is funding Project ECHO learning collaboratives. So those are ongoing. We worked very closely with our Department of Health Professions, which oversees the licensing for physicians, nursing, and dentistry, and implemented the Centers for Disease Control opioid prescribing guidelines. Another priority population are those individuals that are justice involved, so working closely with our Department of Corrections and in extending trainings to their staff, and of course working with our managed care organizations to increase our network capacity and provide those care coordination activities. Next slide. However, our work is not done. In 2018, Virginia has estimated over 1,200 opioid fatalities. 55% of those contributed to fentanyl. And we're also seeing an uptick in non-opioid overdose deaths. In 2018 compared to 2017, the cocaine overdoses were increased by 11.5% and fatal methamphetamine increased by 44%. So this message is it's not a crisis of opioids, this is a crisis of addiction. Next slide. So Virginia's, this is our evolving strategy to address the addiction epidemic. We're looking at how to reduce risk of addiction and overdose, reduce stigma, increase access to medication-assisted treatment and all levels of care, and then focus on priority populations. Next slide. And for Medicaid, our focus are pregnant and parenting women with substance use disorder, those that are justice involved that will be eligible for Medicaid or Medicaid expansion, and then those individuals that are transitioning from an acute care setting. Next slide. So some efforts we made in February of this year, we issued a best practices bulletin and also provided a training to increase access to care. We did remove the prior authorization for our preferred product, up to 24 milligrams of the Suboxone film. We removed an automatic lock-in into our patient utilization monitoring program or a PUMPS program for individuals that were receiving a buprenorphine product. We encourage same-day billing of both medical and behavioral health services. So if an individual she's going to her provider for an obstetric appointment, she can also have a prenatal care appointment as well as an appointment for medication-assisted treatment and counseling all on the same day. We did require, this was also part of a CMS requirement, that individual providers in all ACM levels of care provide access to medication-assisted treatment for their patients that are in need of this. We also encourage medication-assisted treatment during and after release from an acute care setting or an institutional setting, including hospitals, emergency departments, jails, and inpatient rehabilitation. Next slide. And then focusing primarily on pregnant and parenting women, we support integration of reproductive health services and to include contraception and pregnancy postpartum support with addiction treatment. Medicaid and all of our managed care organizations cover all family planning services, including long-acting reversible contraception without a prior authorization. All of our managed care programs have a high-risk maternity program to support individuals with a substance use disorder or substance misuse. And then of significance, Virginia finally expanded Medicaid as of January of this year, and just this month changed the policy so that women that are losing coverage as a pregnant women at the end of their month following the 60th day postpartum no longer have to actively apply for Medicaid to be assessed for the expansion benefit, but they are automatically enrolled. So that was a great change. Next slide. And then also when working with women of childbearing age, DMS support screening for more pregnancies than just using a pregnancy test. I want to give thanks to Dr. Mishka Turplin, borrowing his slide. You want to screen for pregnancy planning, so encourage asking the woman, would you like to become pregnant in the next year? If she doesn't, link her to family planning services, but respect her autonomy and support individual reproductive rights. Next slide. So one of the new benefits under the ARTS program is our preferred office-based opioid treatment model. So I just wanted to highlight here on some of the enhanced rates we have for the prescriber as well as the counseling component. And then the last row is a new benefit within our preferred OBOT model on substance use care coordination. And so we have a rate of $243 per member per month that providers can bill for providing these care coordination activities, and kind of we call that the glue of the team within the OBOT model between the prescriber and the clinician. So here, this is supposed to be a wraparound service, high touch for the member to provide and meet their potential needs. Next slide. So we did look, this is some recent data from our independent evaluator, Virginia Commonwealth University, looking at pregnant women who receive treatment for substance use and opiate use disorders. You can see here kind of the phase in between, this is pre-ARTS and early ARTS, and then almost a year out. And you can see here we have an increase of 28% of pregnant women receiving treatment with a substance use disorder, and an increase of 31% of pregnant women with an opiate use disorder receiving treatment. Next slide. We also looked at the impact of having continuous enrollment. So this is the prevalence of substance use disorder among women with at least 6 months of continuous full Medicaid coverage prior to delivery. And you can see here, these are the statistics or percentages throughout the Commonwealth. And next slide, out of these, this is the rate of women that are engaged in treatment who also had 6 months of continuous coverage. So you can see significantly for opioid use disorder, majority of women are in treatment, as well as with any substance use disorder or alcoholic use disorder. Next slide. I think the takeaway that we are looking at, that the more consistent eligibility and longevity in the program equals more likely to be treated and diagnosed, diagnosed and treated. Next slide. This is just to show you the efforts with, since we implemented ARTS, we have over 445 new provider sites across the continuum of care. And next slide, we also have implemented a Google map that each month we get our network file from our managed care organizations and populate this map so that providers and members can utilize this as a tool to find the network within their locality. And that is it. The next slide has our contact information, and thank you, and I'll pass it back.
Great. Thank you so much, Ashley. And thank you again to all of our presenters today for that great panel and for the great overviews that you provided. We have just rounded out the hour. It's 3 p.m., so we won't have time for a live Q&A, but I do recommend if you would like to type in your questions now, or you can email Katrin Patterson, and I have shared her email address in the chat box. We will reach out to our presenters and have your questions answered, and then send out responses after to everyone. And if you could please fill out the evaluation, the link has been shared in the chat box. So if you could please fill that out so we can take your feedback and improve for next time. And just as a reminder, as we continue in the PRISM Learning Community, please remember to send AMCHIP and ASTO your technical assistance requests. We are here to answer questions, brainstorm solutions, connect you to resources, and facilitate collaboration. So please continue to reach out to us with any technical assistance requests. And a reminder again for the evaluation, and a thank you again to our presenters and our participants.
Thank you.
Mm-hmm. And yes, we will send out a link of the recorded webinar afterwards to all participants. All right, thank you everyone. Bye.